Welcome, everybody. Thank you for making it all the way through the day. I know it's long, a lot of information, but we've got a really exciting session coming up on sleep. I think this is something that obviously affects everybody, and I think it's a really important area for study, and you'll be hearing some really exciting work that's being done to look specifically at patients with autism, their families, and patients with Phelan-McDermid syndrome. So today, we're very privileged to have Dr. Neumeyer joining us, as well as Dr. Paige Hickey-Townsend, as experts in the sleep area. Dr. Neumeyer is the medical director at the Lurie Center for Autism and holds a Mass General Hospital Lurie Family Endowed Chair in Autism. She's also the Associate Professor of Neurology at Harvard Medical School and is a co-founder and co-director of the first Phelan-McDermid syndrome clinic at the Lurie Center. She's really been instrumental in helping a lot of families and really enhancing the clinical services for patients with autism spectrum disorder as well. And in particular, focuses on sleep disorders and bone density and other aspects of disease. Dr. Neumeyer's research and advocacy extends to the Mass General Community Hospital and beyond. And she coordinates autism-related care programs broadly and serves on the PMSF Medical Advisory Council as an active member. Today, she's going to be discussing her latest research on sleep and Phelan-McDermid syndrome and autism, as well as sharing valuable resources, which I think is helpful for all of us to know about for managing sleep disorders. And she's joined by Dr. Paige Hickey-Townsend, who is a postdoctoral fellow at the Mass General Hospital, working with Dr. Neumeyer at the Lurie Center, and also working with Dr. Dara Minowick at the Martinos Center for Biomedical Imaging. Dr. Hickey-Townsend's research there focuses on the neural basis for sleep disorders and disturbances, as well as effects in neurodevelopmental disorders, and in particular their relation to sensory sensitivities and differences in sensory processing. So Dr. Hickey-Townsend is excited to present her work and also to let us know that she's working with families to further understand sleep disorders, specifically in Phelan-McDermid syndrome. And I know they have a booth outside and would be more than happy to talk to folks afterwards. So I'll welcome Dr. Neumeyer to the stage.
Thank you so much. And I know it's late in the day and everyone's tired, and I just had to say this. I hope we don't put you to sleep. Okay, I can still talk like this. So we're going to talk about sleep. I don't have any conflicts of interest. And we're going to start just talking about the importance of sleep and a little bit about sleep in PMS. And then Paige is going to talk about her research. And then we're going to talk about kind of important things to think about in sleep, both for autism and PMS, some tips for success, and then treatment options. So we're really just starting to understand how sleep works. It's really important. This shows different hormones in our body and what happens when we sleep. And like the growth hormone that we all have, it really gets high when we're sleeping. So like if your mother said to you, oh, you have to sleep, otherwise you'll be short, she was right. Because you grow and your growth hormone gets high when you're sleeping. We are trying to better understand sleep, and Paige really is going to talk about the sleep waves that we see, but it's important to know that our bodies relax a lot when we sleep, our blood pressure drops, and then as we're waking up, our blood pressure rises. So there's a lot of important body functions that occur when we're sleeping. And sleep impacts our brain waves, and Dr. Townsend will talk more about that. Sleep is restorative. So this is a picture showing a new system that in the past 10 years has been discovered. It's called the glymphatic system. Not the lymphatic system, but GLYMPH. And it shows, and it kind of helps to filter and carry out brain toxins. And now it's even being implicated in Alzheimer's disease. So sleep is really important for all of us. And we all know what it feels like when you haven't slept. But it's also important for aging. So we all know that sleep problems are prevalent in Phelan-McDermid syndrome. 45% of parents report sleep disturbance in their little ones with PMS. And in children over 18, from the registry, parents reported that 90% have sleep disturbances. So I always say contrast that to about a third of typical children who have sleep disturbances. One of the other problems is that it's hard to evaluate kids. Putting all the leads all over the body to do a formal sleep evaluation of polysomnogram is really, really difficult because most kids just want to rip them off. We see a lot of challenges in kids both falling asleep, staying asleep, and waking up early or waking up in the middle of the night. And these sleep difficulties are really challenging. They are hard to treat, they change with age, and they're less likely to get better over time. Whereas typical kids, they start to get better and have fewer problems, and that's not the case for many children. I hope I'm not depressing you. But there are things you can do. But I will first say, and I don't need to tell any of you this, or any parent of a little baby or toddler, that sleep disruptions are very impactful. And if the kids aren't sleeping, then the parents aren't sleeping, and we have more behaviors. Higher rates of aggression, self-injury, anxiety, hyperactivity, inattention, repetitive behaviors, social reciprocity. If you don't sleep, you're more likely to have seizures. And if you don't sleep, you're more likely to have mood dysregulation. And if you're not sleeping, the parent burden and family stress go up too. So now I'm happy to present Dr. Paige Hickey-Townsend to talk about our research, and then I'll come back.
Hi, everyone. It's really great to be here, and I'm excited to tell you a little bit about the research that I'm doing alongside Dr. Neumeyer at the Lurie Center for Autism on Sleep. So the main goal of our research program is really to understand what the neural basis of sleep disturbances might be in autism, as well as other genetic syndromes like PMS. So what we're doing is we're actually collaborating with other laboratories that will look at sleep in rodent models, for example, the Shank3 rodent model, while we look at information from individuals that have Phelan-McDermid syndrome. So I'm excited to tell you a little bit about some of this human work that we're doing right now. So to study sleep disturbances in this population, we're using EEG. EEG is a really exciting tool because it allows us to have a window into the brain. EEG measures electrical activity that's coming from the brain. And what that looks like is these little waveforms or brain waves. And those brain waves have different characteristics to them, and they're really reflecting how the neurons in our brain are communicating with one another. So for example, how synchronous or how often the neurons are firing at the same time versus how often they might be firing randomly. And what's cool is that brain waves actually change a lot across sleep or while we're awake. So while we're awake, we actually have faster patterns of brain activity, which we call beta activity, which is shown up here in green. And what happens is as we go to sleep, those brain rhythms actually start to slow down and become kind of slower and higher, we call amplitude or height, which you can see in the pink box there. And what's great about this tool is that it's able to tell us when people might be awake or asleep across the night. So we can use that to really understand how often people are sleeping, even if they might not necessarily be able to tell us how often they're waking up across the night. We can also use EEG to look at what we call the spectral content of sleep. So this is particular types of brain rhythms like spindles, which are shown on the screen, where you get a little burst of activity that happens for a short period of time. And what's useful about looking at this type of brain activity is we know where in the brain it's coming from. So if we're seeing differences in that type of brain activity, that can give us a clue about where in the brain we might be seeing differences that are related to challenges with sleep. In particular, our research is really interested in a particular pattern of brain activity called spindles, which are short bursts of 12 to 15 hertz activity. And again, they look kind of similar to this waveform that's shown here in blue. And it's a characteristic of what we call non-rapid eye movement sleep. What we know about spindles is that they're generated by an area of the brain called the thalamic reticular nucleus, which in this figure on the screen here is shown in red. And that area of the brain has a bunch of neurons that are inhibitory, so they're blocking any activity from happening downstream in the circuit. And so we're able to really tell if there are differences in these spindles. It could be something related to this circuitry here. Spindles are also really important for a couple of different functions. They have a really pronounced role in memory consolidation. So for example, having more spindles after you learn something, you tend to have better memory the next day. But we also know that they're really important for maintaining sleep across the night. There have been a bunch of studies showing that when spindles are occurring, if you hear a sound being played, your brain actually has a reduced response to that sound. So that's suggesting that it might be helpful to keep you asleep across the night, where you're able to filter out information that might be going on in your environment to keep you asleep. There have also been other studies showing people who have higher spindle density also are able to stay asleep even if they're in a noisier environment. So again, really kind of pointing to a role of these brain rhythms in sleep maintenance and keeping people asleep across the night. So what we predict is maybe there could be disruptions in this thalamicortical circuitry with the thalamic reticular nucleus kind of at the heart of that. And if we see disruption in the circuit, what that might look like on the EEG is fewer spindles. And we can also see if fewer spindles are related to sleep disturbances we're seeing across the night. So to measure this brain activity, we're actually making use of wearable EEG headbands. And what's great about this, this technology really is that it's a lot easier to put on, it's a lot more comfortable to sleep in, and we're actually able to mail them to people all across the country. So this means that if you don't live close to our location in Boston, you can still participate in the study. And even if you do live in Boston, you know, it might be more comfortable to sleep in your own home, in your own bed, and have a little bit more time to practice with this equipment before you come into the laboratory or participate in the study. So this is the tool that we've been using. And the beginning of our study is really focused on giving participants a chance to practice with or become desensitized to this equipment. We know that it might take some folks a little bit longer than others to be able to tolerate having this type of equipment touching their head. So we provide families with a mock or practice headband. So it looks and feels just like the real one, but the EEG part is just taken out of it. And families are allowed to practice with the headband for up to 2 weeks prior to participating in the study. And during this practice period, we actually give families booklets with different modules to work through to learn how to adapt to wearing the headband at night. So this is just one slide. We have various social stories, a paper version, a video version, where we have families start off by having their child just touching the headband in their hand, and then working gradually down the line through modeling, practicing in short increments, all the way up until they're able to lie down in the headband and eventually sleep in it overnight. And what's helpful is we also have a member of the Lurie Center who is a behavioral expert, and she is consulting with us on this study and helping families kind of tailor this desensitization protocol so that it's meeting the needs of each individual child, since we know that each child might have a different experience learning how to practice with this headband. We also have families keep track of their practice so that we're able to learn from their experiences as well. We really want to make sure that this protocol is as applicable to as many people as possible. So it's really important at this stage of it that we're getting feedback from the participants and their families on how it's going. After the participant is able to sleep in the headband for one night, we are able to mail a real headband to the family. And at that point, the child would have the goal of sleeping in that real headband for 3 nights. And what we're collecting is data about spindles. So that's kind of that marker of how well the circuit is working. And we're also able to measure sleep quality. So again, this can be really helpful in getting more objective information about when people are awake or asleep across the night without necessarily relying on them to be able to tell us that they were awake, however long across the night. Another avenue that we're really interested in looking at is whether or not these sleep disturbances could be related to differences in sensory processing or sensory sensitivities that we see, such as having difficulty with loud noises or repetitive sounds. And the reason why we think these might be related is, at least in autism, we do find that sleep disturbances and sensory sensitivities are correlated with one another. So having more sleep disturbance, you also tend to have more sensory sensitivities. And we think it could kind of boil down to it being resulting from the same circuitry here. So that same area of the brain that produces spindles also plays a really important role in filtering sensory information from our environment. So for example, it's the summertime right now. If you have an air conditioning vent that might kick on, you might eventually not pay attention to that anymore. But if you're not able to filter that out, that noise could be very overwhelming to the brain to have to keep kind of focusing in on that amongst all of the other important information that there is out in the world. So what we're doing is actually investigating how the brain is responding to different sensory information, particularly sounds, using more traditional EEG equipment. And our hypothesis would be that these spindles would be correlated with the brain's responses to auditory sounds, and that would be related to both sleep disturbances and sensory sensitivities. So for those who are able to come in person, we have an optional part of our study as well, where we bring participants into the lab and we have them complete a traditional EEG recording where they're listening to different tones and clicks. Again, we recognize that some people won't be able to come into the lab, but this is just another kind of optional piece of the study that we're doing, and we're really hoping that this information will be helpful for us to figure out if this circuit might be different and give us a place where we might be able to target for treatments going down the line. All right, and with that, I'll hand it back over to Dr. Neumeyer.
Getting a little exercise. Can you hear me now? Great. Okay, so 4 A's of sleep. It's really important. Ideally, your pediatrician, your family doctor should be asking about sleep at every visit. And so what I want to do is give you the information to think about the kinds of things that are important, like bedtime resistance. How long it takes before, when your child goes to bed, between the time they go to bed until when they fall asleep. So we call that sleep onset delay. Because if it's more than half an hour, that's not normal. You should fall asleep within about 15 minutes. And if you've ever laid in bed for half an hour, it's not so much fun. It's not comfortable. So usually people fall asleep within 15 minutes. Sleep duration, how long you're sleeping. Are you snoring? Are there nighttime awakenings? And what does the bedtime routine look like? So does your child fall asleep in the bed, or do they need other things to help them fall asleep? Do they need to fall asleep on the couch with someone rubbing their back, or in a stroller, or in the car? Because how we fall asleep the first time during the night is how we fall asleep the second and third time, because we all wake up a little bit and then fall back asleep again. So these questions you should think about. And then your care provider may want to gather more information. So sleep logs are basically measuring, or the parent writing down, what time did I put them to bed, when did they fall asleep, how many times did they wake up, and how long did they sleep over the whole night. And that can be really important for someone who's trying to evaluate a child, where the sleep problems are. I always ask about the environment. Again, where are you falling asleep? Is it in your bed? Is the light on? Is the room hot or cold? Because we know that it's where you fall asleep the first time is where you need to stay asleep. So kids who are falling asleep in their parents' bed and then carried into their own bed, they're not going to stay there for the most part, because they know how to fall asleep in one bed. And imagine if you were carried in the middle of the night to a different place, you would wake up and like, where am I? So bedtime associations are really important. And then are there other things that could impair your quality of sleep? Reflux, anxiety, medications, and seizures, all of those things impair sleep, or can impair sleep. So if you make a change, you add a medication or you change a behavior, then you want to see, is that working or not? And so there's this quality improvement program that you may have heard of, where you do plan, do, study, act, and just see, is it working? We tried one thing, did it work? No, okay, let's try something else. But you just try to break things down, track improvement, and try something new, a small test of change, and hopefully make improvements. So for tips for success. So when a child or an adult isn't sleeping, often there's a behavior challenge as well as maybe a physiological challenge. But the physiological challenge, child can't fall asleep, is going to provoke behavior challenges. So the child can't sleep, so the parent rubs their back. And then the child learns to associate the back rubbing with falling asleep. So then they can't fall asleep without the back rubbing. And we know this even from little infants, that it's hard to fall asleep on your own. You have to teach a child to fall asleep. So someone who's not sleeping well isn't bad because they don't know how to fall asleep. They just don't know how to fall asleep. So bedtime routines can be changed. For some kids who are motivated, there's a tool called a bedtime pass, where you essentially give the child a reward for staying in their bed all night. And so that can work for some kids. Using light timers, which are now easily available. Basically, the light color changes or the light turns on when it's time to get up, so the child knows when to get out of bed. And then having a very calm and predictable environment is helpful for the child. Social stories are great. First, I brush my teeth, then we read a story, then I get into bed, then, I don't know, my parent sits with me, and then the lights are out, and then I go to sleep. So those are some things that can be helpful. Sometimes you do need to refer to a sleep specialist when things really aren't working. We'll talk about melatonin, and if the child is snoring during the night, or you hear them, their breathing change, like they stop breathing for 10, 15 seconds, then that's the time that you do go to a sleep specialist, or you go to an ear, nose, and throat doctor to get evaluated for sleep apnea. Because a lot of children have large tonsils, and a lot of kids with PMS have low tone, and the low tone can predispose you to having snoring and sleep apnea. Other things that are important. Sunlight is really important. So in the wintertime, for some kids, it's very useful to have a sun lamp in the morning to kind of establish the biorhythms. And then you want to encourage behaviors that promote sleep. So exercise, exercise, exercise. As much as you can get the kids out exercising, they're going to sleep better. Not feeding someone right before they go to bed. And that can also be a sleep association. Full belly, fall asleep. And you want to separate meals from falling asleep. And then afternoon napping, for me, is bad. If I sleep in the afternoon, I can't fall asleep at night. But for a lot of people, it's like that. So avoid naps. And I'm obviously not talking about the toddlers who need to nap still. So routines. So we often don't like to have very strict routines, but bedtimes, they work well. So the routine should be done in the same order each night. A little chart, like you see here, can be very helpful. You just point to each item. We're going to do all of these things. You make your own chart to suit your own routine. The routine should not last more than an hour. So maybe taking a bath, I mean, if baths last 30 minutes, that's fine, but you don't want it to go on for 2 hours. So, and do the stimulating or the things that are excitable very early in the routine, so you have the more quiet, relaxing things near the end. And then choose a consistent bedtime every night. So some kids get a second wind. You don't want to be putting them to bed if you know they always get a second wind around 7:30 in the evening. That's not the time to put them to bed. Wait a half hour or an hour and then do it. So you kind of have to follow their rhythms also. And you know, for parents who are working late and want to shift their kids so they wake up later and go to bed later, that's fine. Just make sure your child is still getting enough sleep for the whole night. Yeah, so if a child takes more than an hour to fall asleep, it might be too early and you just need to shift their bedtime to an hour later instead of trying a medicine. So now we're going to go on to medications. Medications are useful, but they can't be just done alone. So sometimes the behaviors are what you need to do, but sometimes the caretakers aren't able to implement an intervention, or they're not willing to. And it might be they're not willing for very good reasons. There's 4 kids in the house, and there's 2 bedrooms, and one child is keeping everyone else up, and you don't want to, you know, engage in a long battle. The kid has to go to sleep quickly so that everyone else stays asleep, or the child can't wake up during the night because then everyone else is up. And sometimes the intensity of the symptoms just reaches a crisis. So then pharmacological interventions can be very helpful, and then hopefully once you get the child sleeping better, you can work on the behaviors. So surprisingly, there are no FDA-approved medications for sleep in children. None. But we do use a lot of medications off-label. And melatonin is probably the most common one, and that can work very well for a lot of children, you know, in low doses even. I do want to warn people that there's very many products out there for melatonin, and ideally you want to use a product that's been approved by another kind of a pharmaceutical monitoring organization, and I don't know why I forget the name right now, but it will come to me. So the doses vary, but if you stick with one brand, usually that brand is pretty good. You know, all the pills in the bottle will be about the same amount, but it might be that if you buy brand X and brand Y, 1 milligram in one bottle isn't really 1 milligram, and 1 milligram in the other bottle might be a little more than a milligram. So The other important thing to know about melatonin is that some kids wake up after 4 hours and they're awake. And some kids get bad nightmares with melatonin or very intense dreams. So it's not going to work for everyone. And if your child is waking up, then you know you tried and move on. Because you usually know with melatonin, if the dose is high enough, within a couple nights, whether it's working or not. You don't have to be on it for a month. You know within a night or two. And if you start at 1 milligram and it's not working and you go up to 10 gradually and it's still not working, you're done. Clonidine is a blood pressure medicine, but it makes kids sleepy. It's often used for behavior and hyperactivity, and for that it's approved in the United States for children. But it's not approved for sleep. But it works well, but it's not long-acting if you take a normal pill, which you chew or crush. And so often the clonidine can work to help you fall asleep the first time, but maybe not the second or third. So it doesn't usually wake kids up, but it just stops working after about 4 hours. And there is a long-acting clonidine, which can be very helpful, but that product you have to swallow whole. They don't have a liquid formulation that's a long-acting one. So the other thing is you want to treat medical comorbidities. You want to make sure you're treating the sleep. If the child is constipated, you need to treat that. That might improve their sleep alone. You need to make sure the seizures are under good control, that they don't have reflux, because when you have reflux and you lie down, it gets worse. So it's not going to feel good if you have untreated reflux every time you lie down to go to bed. And obviously, if you're in pain also, it's really hard to sleep. So I just talked about melatonin, and the alpha agonists are clonidine and guanfacine. And they're approved for attention, and they help with tics and OCD. And then trazodone is an old antidepressant that didn't work so great for depression, but everyone slept great on it. So now we use it for sleep. And that can work very well for a lot of people, and it helps you fall asleep and stay asleep all night. So the next group of medicines are the atypical antipsychotics. And you might have heard from Dr. Kohlenberg that they can provoke catatonia, and or the child can have a bad reaction to them. And in the pre-puberty population, these can work well, especially in small doses for some kids to help them sleep. It's not the first medicine we go to, it's the third or fourth medicine, but they can be useful. And then some children have restless leg syndrome, which is just where they're moving around a lot. And what's interesting is that can be due to an iron deficiency. So not getting enough iron. It's easy to check with the blood test, and then we just give supplemental iron for those kids, and that often can help it. So Benadryl can also be a great medicine for sleep or helping the child to quiet down. Try it once. If you are going to try it in the afternoon to see if it makes your kids sleepy, because a lot of kids have a paradoxical reaction where they wake up more. And you don't want that happening at 9 at night. So try it in the afternoon, see if it makes them sleepier, and then you can try it at nighttime. It's not a good medicine to give every night, but on occasion it works well. And if you have a child with allergies in the springtime, it can serve two functions. And then amitriptyline is an old antidepressant, which I don't know why, but for many children who have kind of genetic autisms, it can be very helpful for falling asleep. And it has anticholinergic effect, which some of these other medications have. And what's important to remember is it can make you more constipated. So we always think about all the other things the medicines can do in a vulnerable population. So when you start a medicine with your doctor, ask when you're going to get followed. Make sure that they're going to check in with you, because it should occur within 2 to 4 weeks, by phone, by Zoom, however, in person. And usually then we make adjustments to the medicine. I'll ask my patients just to message me through the patient portal what's happening, so we can just make adjustments quickly. And let us know how it's going, what other supports do you need, and then what referrals might be necessary if things are really going south. Autism Speaks has some online resources for behaviors, improving sleep, for teens, for children, and so it's an easy Google search for those. And so we have talked about how important sleep is, some of the research that we're doing to understand sleep in individuals with PMS, what to talk about and what to think about with sleep, and then hopefully some tools and tricks to improve sleep for your children. So that's it, I think, yeah?
Thank you, Doctor. All right, we're going to get the poll EV up so you guys can ask some questions. Please just go ahead and hit that QR code, type in your questions, and you can upvote as necessary. So a couple to start here, Doctor. The first one, can sleep EEG results, not part of the Lurie study, be sent to Lurie for assessment of spindle activity, or is this not really apples to apples?
I think that's a great question. That's not part of the study we have up and running right now. I could see that being potentially something that could be done in the future. Unfortunately, not part of this study, but the same electrical activity that's recorded during kind of a clinical sleep assessment is similar to what we're recording. So you hypothetically could look at spindle activity from that as well.
Okay, great. Are there any negative side effects in clonidine or trazodone in our PMS children?
So every medicine has potential side effects. I've put we've tried some children with clonidine and it wakes them up. Some parents have reported nightmares with these medicines. So every medicine has potential complications. Clonidine can lower the blood pressure. I've never really seen that as a problem, but in theory, it could lower the blood pressure. So the child, when they stand up, they might get woozy and feel faint. And trazodone has very rare side effects. And one of them that I always talk about with families of children who are not verbal is that in children who've gone through puberty, it can cause very rarely a sustained erection. So I haven't seen it, but because children who aren't verbal can't communicate, you want to empower the parents so they know.
Great, thank you. What are the risks related to long-term melatonin use?
That's a good question. I don't think we really know. You agree?
Yeah, I think it's definitely an open question and an important question as a field of sleep that we should be kind of investigating a little bit more across the board, even in other folks who might use melatonin outside of Phelan-McDermid.
Yeah.
And so there's, I guess, no reasons to not keep a child on melatonin if it seems to be helping?
Yeah, so that's a good point. So I always say that, when you have a child who's on melatonin and is working well, after 6 months or so, just try to cut it back a little bit. And if that works fine, then cut it back a little more. So, you're giving them at least the lowest dose possible, but you may be able to just wean them off because some children are able they've learned how to fall asleep and their sleep improves. So yeah.
Is the Fitbit or other similar sleep devices a fairly accurate monitor for sleep? And if not, are there any devices you would recommend to monitor sleep at home regularly?
Yeah, so that's a great question. So oftentimes in sleep research, we like to use a combination of different tools. Things like Fitbit, what it's really measuring is the amount of motion that your hand is doing, right? So you could think about when you're lying down trying to fall asleep, you might be pretty still, but you might not necessarily be asleep just yet. So I think what's great about EEG is you're really able to get into those brain rhythms that might be changing a little bit more, and able to give us a little bit more detail about exactly when people are starting to fall asleep. However, Fitbits can be really helpful when you want to think about things like circadian rhythms. So for example, are you being active at the same time every single day, or is the time you're falling asleep very variable? Like one night you're going to bed at 8 o'clock, the next night you're going to bed at 2 a.m. So I think in a way, having both of those pieces of technology give us a fuller picture of what's happening during sleep.
So sleep affects behavior. How often should we do sleep studies since we can't fully understand our nonverbal children?
Well, how often? So if a child can't sleep and they can tolerate a sleep study, then you should do it. If they're not sleeping through the night, then a sleep study can provide very useful information about potentially why and how we can better help them. But once you've done a sleep study, you probably don't need to repeat it every year. Unless something changes in how the child is sleeping. And then it might become another time that you want to order one. But most sleep specialists don't order them regularly, I would say.
Great, thank you. What's your advice for early risers? My child goes to sleep okay, but wakes up between 4:30 and 6 a.m.
So, yeah. So the question is when they're going to bed. Like maybe they're going to bed at 6:30 at night. So 6:30 to 4 is 9.5 hours. Well, that's not bad, actually. So maybe what you have to do is shift them a little so that they're going to bed later. And sometimes it can be really hard to shift somebody to a later sleep time. And so you might want to just do it in 15-minute increments. And then you might want to make sure that at 4:30 in the morning, the sun isn't shining in and waking them up. So you have to make sure that the sleep environment is suitable at 4:30 in the morning. And think about, the trash collector is coming at 4:30 in the morning and they're making noise and waking the kid up. So you have to think about lots of different things when you're trying to understand why a kid's waking up and how you can move them to a later time.
So I'm going to guess that this is related to the sleep. So are there any thoughts on CBD and with or without THC?
So GW is a pharmaceutical company, and they recently did do a study of treatment study in children with autism. And it was placebo-controlled, so half the kids got the medicine, half the kids got something that looked like the medicine. And what they learned is that there was no difference. And they looked for a lot of different things. It was a safety study, but so anyway, they looked for a lot of behavior changes, and they didn't find any. So I don't think CBD is that useful. THC, I don't like using THC because some children who take it get psychotic. I don't think it's regulated, so I don't recommend it.
Is the band used, the DREAM band, DREEM? Is this being studied in other NDDs?
Yeah, so the headband that we are using is called Dream 3 right now, and we're actually completing a fully remote study right now looking at sleep in autism spectrum disorder, and we also are collecting data from adolescents who are neurotypical as well. And I should also mention we're, in addition to looking at Phelan-McDermid syndrome, we're also measuring sleep in Fragile X as well as 16p11.2 deletion syndrome. And again, we're working with a lab over at Brandeis University in Massachusetts who's looking at sleep in the corresponding rat model as well. So we're really hoping to see if there's any converging evidence here between what we're seeing in people as well as in our animal models. And then we're also really interested in seeing if there are any differences between these different genetic syndromes as well.
How often does night awakening need to occur to be considered a problem?
So waking up at night isn't a problem unless you're not going back to sleep. And we all wake up probably twice or 3 times during the night.
It's very common to wake up a few times and just for kind of short stints of time.
Yeah, usually we just roll over and fall back asleep. So it's a problem if the child is up for, I don't know, more than 15 minutes and they're not able to fall back asleep. Because then it's a problem for the parents because their sleep gets interrupted. And sometimes kids are up for a while during the night, but they're quiet in their beds, and as long as they're getting enough sleep during the night, if they're up for 15 or 20 minutes, it's probably not harmful, as far as I know, but it's when they're up and then they don't go back to sleep, then it's a problem.
How much time do you recommend between dinner and sleep?
I don't know, probably an hour or more.
2 questions about sleep apnea. Are PMSers at increased risk? And are there other treatments available if a CPAP isn't an option for a younger kid?
Oh yeah, I don't know the numbers, but I think it's more likely in children with PMS. And using a sleep apnea device is really hard for kids, whether they're typical or not typical. Usually, tonsillectomies in children help to solve the problem. But sometimes it doesn't. And then you need to go to other devices, and that is really not my area of expertise. So I would say you have to talk to a sleep specialist or an ear, nose, and throat doctor who is very interested in sleep, and they can help you.
Would extended melatonin be safe for kids? I can only find extended release for adults.
Yeah, it's not FDA approved, and I recommend extended melatonin. And the way to think of it is a 5 milligram extended release melatonin is like getting 2.5 milligrams when you go to bed and then 2.5 milligrams in the middle of the night. So it's 2.5 plus 2.5 is 5. So that's not actually a lot. A lot of the pediatric melatonins are 3 milligrams. They're between 1 and 3 milligrams. So the biggest challenge is just swallowing the pill. But if you have taught your child to swallow a pill, congratulations, because then you can try the long-acting. And sometimes we use long-acting clonidine also.
What would be the next step if the sleep study is normal, but your child is not sleeping?
Well, so again, we need to talk about, are they not sleeping because they're not falling asleep, or they're waking up too much during the night, or they're waking up too early. So it depends on all of those things, where we go with our next step, and what the sleep behavior is like in the environment.
My teenage daughter struggles to fall asleep. Would 14 hertz spindles during stage 2 within normal limits? I don't know if I'm saying that right.
Sorry, do you mind just repeating the question?
My teenage daughter struggles to fall asleep. Would 14 HZ spindles during stage 2 within normal limits?
So I think the question might be asking, would we expect that the spindles would be within normal limits there if they're having trouble falling asleep? I think the answer is we don't know. It could be a lot of different reasons why people are having trouble falling asleep, and we expect that there could even be different kind of phenotypes as to what part of the circuit could be going awry. Sometimes it's not just the sheer number of spindles, but when those spindles are happening. They actually occur at very specific times, and if that timing is shifted a little bit in one way or another, or it's not as consistent, that can also be a challenge sometimes. So I think we'd need a lot more information to be able to know for sure, and it might not necessarily be one size fits all.
Is your sleep study for the USA only?
Right now, it's only for the US only.
Can the headband measure sleep apnea, and how much snoring defines apnea?
The headband right now is not approved to study sleep apnea. And in our study, we actually try to screen out for sleep apnea if possible, just so we're able to really understand what's happening with brain rhythms that might not be affected by other sleep disorders, aside from.
Yeah. So sleep apnea, you have to measure the breathing. And so this is not measuring breathing.
Okay, and I believe last question here. Do children going through adolescence need more sleep medically, and how many hours is ideal?
Well, yes, they need more sleep. Adolescents need more sleep, and they're more driven to stay up later, which is why so many teenagers are waking up at 10, 11, 12 at night, because they're just driven to stay awake. Their biorhythm kind of switches, but they need more sleep. So many, like 10-year-olds might be doing fine with 9 hours, and then they hit adolescence and they need 10. And they're not getting it, and so then you see a lot of, or at least typical teenagers, then they'll sleep 12 hours on the weekend because they're trying to catch up. But teenagers need more sleep.
One more just popped in. Are you still accepting patients for the study?
Yeah, so we actually just started recruiting around April or so. So we're currently recruiting individuals between 12 and 19 years old to participate. And as I mentioned, right now we have an option to do the study completely remotely. I know you all have come from all over the country here, and we know some of those places might not be Massachusetts. So yeah, anyone between 12 and 19 is eligible to participate.
And I will just add that we're going to be recruiting for the next couple years. So if you have an 11-year-old, then when they turn 12, we'll recruit them. We'll be happy to have them. And we are doing right now older children, primarily because the Dream headband isn't adjustable for head size. So the kids their heads are too small for that. So hopefully in the future we'll have a product that we can use that measures sleep in children with smaller heads.
Okay, thank you, doctors. Really appreciate the message and all of the questions answered.
Thank you so much.
Thank you.